So I'm new people, okay, and any doubts are there in the last 5 or something we can do so that
Yes.
background noise can reduce. Okay, so last class we have seen the hyperlipidemia and what are the causes for hyperlipidemia and some of the drugs which are given for the treatment of hyperlipidemia. And the chemical composition also we have learned, that is what are lipids and what are lipoproteins. The difference between lipids and lipoproteins also we have discussed, and chemical composition also we have discussed of lipids and lipoproteins. And coming then the composition of lipoprotein, what is made, that also we have discussed. And then types of lipoproteins also we have discussed, and various types that also we discussed. And that also we discussed what is the difference between HDL and LDL, and how the HDL and LDL metabolizes, that also we discussed. And what is the main function of LDL, and what is the main function of HDL, that also we have discussed. And LDL, we have seen that it transports cholesterol or cholesterol esters from tissue to the liver, and where it gets metabolized and excreted. Lipoproteins or lipids will be excreted. That means HDL reduces the blood cholesterol, and whereas LDL, it transports the lipids or lipoproteins to the peripheral tissue and causes the atherosclerosis. Oh, so that also we have discussed. And then the difference between those two we have discussed. And if there is an increased levels of lipoproteins and lipids, what happens, that also we discussed. And mainly these increased levels of lipids or lipoproteins, they cause the coronary artery diseases, and especially the atherosclerosis, and that we discussed. And what are the types of hyperlipidemias, that also we discussed. And the difference between these types also we have discussed: type 1, type 2, type 3, and type 4 and type 5. All this. So in each case, what is the difference also we have discussed. And then coming to the drugs, what we the various classes of drugs, that we started with statins. And the statins of the class, so which examples we have here, that is atorvastatin and lovastatin. And atorvastatin, these statins, so we discuss mechanism of action, they inhibit the HMG CoA reductase. So, and well, if this is inhibited, cholesterol will not be synthesized. So once if cholesterol is not synthesized, endogenous cholesterol starts metabolizing. Endogenous means which the cholesterol which is present with the tissue, that starts getting metabolized, and then the cholesterol levels in the tissue will be reduced. So that's how, and circulating cholesterol also will be reduced. This is statin. And next one is fibrates. So how the fibrates, that is clofibrate or fenofibrate or cipofibrate and niacin. So the niacin is another class of drug. This also we have discussed, and their mechanism also we have discussed. That is it's peroxisomal, okay, activating receptor alpha, okay, alpha A, okay, especially in the liver and muscle. So, and this causes the beta oxidation of, okay, fatty acids. So this is how the fibrates they cause the, okay, they reduce the cholesterol, that is free fatty acids, circulating free fatty acids reduced. So here fibrates mainly they reduce the circulating free fatty acids. So free fatty acids, how they are reduced means, here fibrates bind to the receptor, protein coupled receptor, then thereby they reduce the free fatty acids. This is the mechanism how it will be reduced. Okay, so it is inhibitory action. So, and reduced free fat release cause the reduced VLDL, and we know that LDL is synthesized from the VLDL. If there is no VLDL, then the cholesterol levels or lipoprotein levels will be decreased. This is with the your next is bile acids. Okay, so bile acids, these are resins actually, and nitrogen containing compounds. Now normally these are, and bile acid sequestrants also. We know that cholesterol is metabolized in the liver, okay, and excreted to the intestine. And the cholesterol, how it is metabolized. So the cholesterol is metabolized into bile acids. So yeah, either you have a cholic acid or taurocholic acid or lithocholic acid. So these are from cholesterol will be converted into cholic acid. So cholic acid is a bile acid, and bile salts, it will be converted into bile salts also. So cholesterol will be converted into bile salts like lithocholic acid and taurocholic acid. So this is how it gets metabolized. So in liver, cholesterol gets metabolized into its bile acids and bile salts. So, and these will be excreted. So through the metabolism in the liver, the cholesterol levels you can reduce in the, that is plasma cholesterol levels or cholesterol esters, you can reduce if you increase the that is cholesterol metabolism in liver. So here bile acid sequestrants, the compounds which are containing quaternary ammonium compounds, they sequester or they bind with the cholesterol, or they no, not cholesterol, bile acids or bile salts, they bind, and these are non-absorbable resins, so they'll be taken orally, non-absorbable resins which contain the quaternary ammonium. So these quaternary ammonium compounds bind with the bile acids, and then they'll not allow, okay, these bile acids reabsorption, and then it, once this cholesterol acid or bile salts and bile acids are not reabsorbed, then what happens is that it promotes the metabolism, that is promotes the metabolism of cholesterol. So here bile acid, this is the mechanism based on the cholesterol metabolism. So the cholesterol metabolism, if you see here, the circulating cholesterol, okay, are cholesterol esters, so they enter into the liver. When they enter in, once they enter into the liver, in the liver, the cholesterol or cholesterol esters, they will be converted into bile acids. Cholesterol will be converted into bile acids, and these bile acids are excreted, okay, through the, and that is transported to the intestine. They'll be transported, these bile acids. So you have the cholesterol will be converted into bile acids, and bile acids are transported into the intestine, and then they are excreted. So this is how the metabolism of cholesterol takes place. And now what you are doing is that you are giving this resins, non-absorbable resins they are. So these resins bind to the bile acids, and then prevents the reabsorption of cholesterol, and they'll get excreted as such. So now in the circulating, okay, since you are preventing the reabsorption, this in turn promotes the excessive cholesterol metabolism. Excessive cholesterol metabolism, that is endogenous cholesterol metabolism, and thereby reduce the circulating cholesterol. So if you see here, that is a, here you have bile acid sequestrant, that is a cholestyramine. Okay, this is cholestyramine. So cholestyramine, the quaternary ammonium compound. Another one is that cholestipol. Another one is, this is also quaternary ammonium cholestipol. And so these compounds especially, and these are non-absorbable resins. Okay, and as I told you, and so these compounds non-absorbable, they bind to the bile acids. Okay, bind to the bile acids, and then they'll not be reabsorbed. Okay, so then bile acids are not reabsorbed. So here what happens is that it promotes the, okay, that is cholesterol metabolism in the liver. And then here next one is the synthesis of LDL receptors, increase the to allow increase cholesterol uptake for bile acid synthesis. So liver also we know that, so liver can uptake the LDL. So first thing is that this bile acid sequestrants, what they'll prevent the reabsorption and promotes the cholesterol metabolism. Another way also is that here in the liver uptakes the LDL and causes the metabolism of LDL. Okay, so this is how these non-observable resins, they inhibit that is you can use in the treatment management of hyperlipidemia. So the resins first, they inhibit the thing is that reabsorption of bile acids. So we know that bile acids are metabolites of cholesterol. Okay, the bile acids metabolism takes place in liver. Okay, and then here another way, there is another way also. They increase the sensitivity of or LDL towards the receptors which are present in the liver, and then bile uptake, that is cholesterol and LDL. So then they will reduce the, so, and once if these LDL receptors are increased and the circulate, because LDL, last class we have seen, okay, I'll show you that. You can see that here there is another way of mechanism here. Okay, so if you see that this is, we already discussed what it is, bad cholesterol and good cholesterol. So when I say good cholesterol, okay, so it transports the cholesterol from tissue to the liver. Okay, whereas and LDL is, as we told, that it is transports the cholesterol to the tissue. But there is another way also. LDL can be reuptaken by liver through the LDL receptors. LDL receptors. So now here we are talking about the non-observable resins, that is the cholesterol or cholestyramine. So cholesterol here in the liver, they get metabolized, okay, into bile acids and bile salts. Then they get excreted. Okay, and then your resins, what they do is that with the bile salts and bile acids, they form the complex, and this complex is excreted, and then the reabsorption of cholesterol is, that is bile salts, will be prevented into the systemic circulation. Now in the systemic circulation, the cholesterol levels are reduced. Okay, and another way also is that once if cholesterol levels, bile salts are not producing, okay, and that is a feedback mechanism now, because the bile acids are not getting reabsorbed. So that means you need bile acids here. So that's why what happens is the LDL will be transported to the liver and by reuptake mechanism, and okay, and the cholesterol level, further cholesterol levels will be reduced in the circulating plasma, that is circulate in the plasma, circulating LDL will be reduced. So this is how that is resins will work. Okay, so bile acid sequestrants, that is cholesterol, or you have this is cholesterol and other one is cholesterol. Okay, next another class of drug. This is a newer class of drug. Okay, so and so these drugs like ezetimibe. Okay, so these drugs, they bind to the mediators of cholesterol absorption, gastrointestinal. So the cholesterol absorption takes place through these mediators. Okay, Niemann pick C1 like C. Okay, 1. So these are Niemann pick C1 like 1. So this is the transporter which is present in the GIT. This transporter, it transports that is helps in the absorption of cholesterol, helps in the absorption of cholesterol. So and this ezetimibe, so they inhibit these proteins so that cholesterol is not transported from GI to into the liver or systemic circulation. Thereby it reduces the absorption of cholesterol, and you can use it, these drugs you can use it in the management of hyperlipidemia. So ezetimibe, so they NPC1L1, this is the protein, okay, which helps in the transportation of cholesterol. Okay, transportation of cholesterol. So cholesterol binds to this protein, and this protein transports from GIT into the systemic circulation. If we inhibit this, the circulating cholesterol will be reduced. Okay, so this is another, that is one class of drug, and this is same. This is another class of drug. So here it inhibits the microsomal triglyceride transfer protein. Okay, so this is the protein which inhibits lomitapide. So this drug, especially this is a newer class of drug. Till now we used to have only statins, okay, R fibrates, and then we used to have these resins. Apart from that, these are the newer class of drugs. The first one is that which inhibits the cholesterol transporter from the GIT. Okay, GIT. So the second one is that lomitapide. Lomitapide is the microsomal triglyceride protein transferase. So this is transfer protein. This is a which inhibit this lomitapide inhibits this MTP or MTTP, you can call it. So this is necessary for the making up of VLDL. Okay, VLDL assembly. We know that VLDL is assembled in with the triglycerides are required for the assembly of VLDL, very low density protein, which is made in the liver. So to make the VLDL, you need triglycerides, free fatty acids, okay, and protein, cholesterol. So all these components are assembled and VLDL is made. If triglyceride is not there, okay, triglyceride is not there, VLDL cannot be synthesized. And we know that LDL comes from VLDL via IDL, VLDL, IDL, and LDL. So if VLDL is not there, LDL cannot be synthesized. VLDL, so this triglyceride is one of the component of VLDL. Very low density triglyceride is one of the component of VLDL. So we are inhibiting the transport of this triglyceride by inhibiting the transporting protein. So example, you have lomitapide. And then another one is that CETP, cholesterol ester transfer protein. Okay, okay. Cholesterol ester. The first one you see that this is cholesterol from GIT. The next one is that cholesterol ester. Now we know that lipids, okay, this is the combination of alcohol and the carboxylic acid. And cholesterol is an alcohol. And ester, how it forms? So if free fatty acid combines with the cholesterol, and cholesterol ester will be formed. So here that cholesterol ester transferase protein, okay, inhibitor. So this class, so it is a membrane class of drug that inhibits the cholesterol ester transportation. So cholesterol esters are all again the components of VLDL proteins. Okay, so and these drugs have not yet come into the market, but they are in the phase 2 and clinical trials, phase 3 these two are in phase 3 clinical trials in running in. Okay, so these are the drug anacetrapib and evacetrapib. So these two are the drugs. So these are the various classes of drugs where we use for the management of hyperlipidemia. So the drugs which are used for the hyperlipidemia or this, okay, so statins, fibrates, niacin, and then bile acid sequestrants, and then you have another class of drug, okay, NPC1L1 protein inhibitors, and another class of drug that is lopetamide, MTP inhibitors, okay, like triglyceride protein transferase inhibitor, and then another one is that CEPT inhibitor, cholesterol ester transfer. So these are the drugs which we can use for the disease management, that is hyperlipidemia or hyperlipoproteinemia disease. So this is with this class we finish this topic. Next we go to some other topic. So next topic we take up is the diabetes, anti-diabetic drug. So and anti-diabetics. So these are the drugs which are normally used for the disease management of diabetes or diabetes mellitus. Generally, we call it as diabetes mellitus. And the drugs which are used for the disease management are called as anti-diabetic drugs. So diabetes, actually, it is a group of diseases. Diabetes, it is not a single symptom here. So it is a group of diseases. So where you have the results in the differences in the or high blood glucose levels. Okay, diabetes group of diseases, and which results in the there is variation in the blood glucose levels, that is increase in the blood glucose level. So these are the blood glucose levels of in a diabetic patient. You can classify normal. This is the chart. Okay, so micro, that is mg per deciliter. Mg per deciliter, that means moles per liter. Moles per liter. You can convert this mg per deciliter, that you can convert into moles per liter. So, and diabetes, we know that it is blood glucose level, variations on the blood glucose levels. So that is generally diabetes mellitus, it is the increase in the blood glucose levels or plasma levels of glucose. And then normal glucose levels, that is fasting, and then after eating, okay, and just ate, and after 3 hours of eating. So if we consider the fasting levels, when we consider the fasting levels, normal it will be between the 80 mg to 100 mg per deciliter, and that is normal person. And pre-diabetic, one second, pre-diabetic, and pre-diabetic, it is 101 to 125 mg per deciliter, okay, per deciliter. And that you can convert, okay, this is when you convert this mg per mil, that is millimole per liter, then it will come to the micrograms per ml. You can convert that millimoles into micrograms per liter. So it comes in the microliter only. Okay, micrograms only it will come. And normal patient, okay, of the diabetes, so it is 100 to 80 to 100. And then next one, pre-diabetic will be 100 to 125, that is 101 to 125. Fasting levels only we consider. And diabetic patient, so this is 126 plus, above 126, okay, above 125, you can call it as a diabetic. The person is having, the person is diabetic. This is all levels, sugar levels for fasting levels. So sugar fasting levels. And as you know that after eating or after eating of 3 hours, then there is a shoot up of glucose levels, that, but generally we consider this fasting levels. So the fasting levels will be of normal person, glucose levels will be 80 to 100. And pre-diabetic, that is onset of diabetes. And here 101 to 125 mg per deciliter. Diabetic you can classify if you have the blood glucose levels, that is 126 above 125. So diabetes, generally it is diabetes mellitus. If you see that it is of, you know that we have we discussed that it is increased glucose levels, and this increased glucose levels, you can say type 1 diabetes, and where we say that insulin dependent diabetes or hyperglycemia. So this is also hyperglycemia only. And type 2 diabetes. So where you have the little produce of insulin, or there is no insulin. Okay, insulin is not produced, type 1 diabetes. And generally this is, we know that it is because of the autoimmune disease, where the beta cells of Langerhans, okay, that is pancreatic cells, will be destroyed because of the autoimmune disease, and there is no production of actually insulin here. So this is insulin dependent, okay, diabetes mellitus, type 1 diabetes. Second one is that type 2 diabetes. So type 2 diabetes, it is insulin non-insulin dependent diabetes mellitus. Okay, and here insulin secretion will be there. Okay, it's not that insulin, even the insulin secretion is there, you will have the increased glucose levels. That is because maybe sometimes the cells may become the resistant to the insulin. Okay, so that is type 2 diabetes. Another one is that which is not commonly observed, which is not commonly observed, gestational diabetes, and that you will observe in pregnant women. Okay, pregnant women, gestational diabetes. So that is temporary. Okay, diabetes, this gestational diabetes, and again this will go off once the pregnancy is over. So, or sometimes it may be continued also. So then, how with the diabetes mellitus progresses? Okay, how you have the diabetes mellitus, how it is progresses. And if you have abnormal sensitivity, insulin sensitivity, then it causes the hyperinsulinemia. Okay, abnormal insulin sensitivity, because of the abnormal insulin sensitivity. So whether that is a reduced sensitivity, okay, reduced abnormal insulin is not increased, doesn't. Okay, normal sensitivity and hyperinsulin, okay, hyperinsulinemia. And then here, because of that, what happens is there is a central obesity. Central obesity means so deposition of the fat, okay, around your abdomen. Central obesity. Once this fat is that is big, turns out to be insulin resistance. Okay, if you hyperinsulinemia, insulinemia, and then causes the central obesity. Central obesity here in the sense it is if you have that is a deposition of fat around your waist, okay, abdomen, that we call it as the central obesity, and this develops into the insulin resistance. So then what happens? You have the weight gain is there, and this also can happen. Okay, so if you have abnormal insulin sensitivity, so central obesity will be there. And once if you have the central obesity, weight gain, you know that weight gain, it will happen. And if physical inactivity, if you have physical inactivity, again you will become obese. And then it develops the central obesity, can cause the insulin resistance. Okay. And then you will have the progressive loss of beta cells. Okay. Progressive sometimes. And then impaired glucose tolerance, sometimes improve. And this for this, okay, can be genetic, mainly genetic factor autoimmune disease, and or it can be high glucose levels or high free fatty acids can cause the progressive loss of beta cells and impaired glucose tolerance. And finally, we'll have the diabetes mellitus. So diabetes mellitus progression, if you see, you have the increased weight gain, and or through the increased weight gain is through the physical inactivity and causes the central obesity. And then finally through genetic factors, okay, or high glucose levels or free fatty acids, you'll have the progressive loss of beta cells, and then finally you will have the diabetes mellitus. So this is how the diabetes progresses. And then what are the causes? Causes for obesity, that is, one is the obesity, as I told you, central obesity. Another one is living a sedentary lifestyle or an increasing age and bad diet. So these are the major causes, and we cannot define, okay, we cannot say in a particular person this is the reason. Okay, in one person it can be maybe a obesity, or maybe it can be maybe because of other reasons. And increase in the age, it can be and bad diet, and almost all we say that the cardiovascular diseases and diabetes mellitus, all these we call it as a lifestyle diseases. So it depends upon the lifestyle also, lifestyle also. And sedentary sedentary lifestyle means sedentary lifestyle means here it is that, okay, physical inactivity you can call it as, and physical inactivity, all these comes. Okay, so if you are when there is no physical activity, all these reasons, if you see that, if you we just generally we are trying to do whatever the, okay, activities we are trying to do, this that is we are doing daily, okay, sitting idle, okay, and then watching, sitting without any physical activity, and no socializing, and watching movie televisions or movies, playing video games or using a mobile phone computer for much of the day. Okay, so this comes under the sedentary lifestyle, and this can cause the diabetes mellitus. Okay, so then coming to the glucose, that is glucose blood regulation, which are the things that regulate the, we are the diabetes mellitus, we know that. Okay, so it is increased levels of blood glucose levels. And then the progression of we know that we have discussed the progression, how it diabetes mellitus progresses, and we have seen what are the causes for the diabetes mellitus. Okay, so and next one is that we see the hormones which regulate the glucose metabolism, glucose levels. So these are the two main hormones, peptide hormones you can call them, which regulate the glucose metabolism. So one is insulin, another one is a glucagon. So this is a glucagon, we know that it causes the breakdown of glycogen into glucose when there is a reduced glucose levels. Another one is the insulin. What it does is that if there is an increased increased glucose levels, and glucose will be converted into glucagon. So if you have blood glucose level rises, and then when there is a rise in the blood glucose levels, then pancreas, that is beta cells, will secrete the insulin, then insulin will be taken up by liver, and then glucose will be converted into glucagon. And if you have reduced levels of glucose, then you have the glucagon, that is alpha cells will be secreted, glucagon will be secreted by alpha cells, and then the glucose will be taken up by liver, and then it will be converted into glycogen. So these are the two opposite actions. So one reduces the glucose levels in plasma, another one reduces the, okay, that is, this one increases the this one reduces, and other one increases the plasma glucose levels. So if there is a rise in, or if there is a fall, okay. Another hormone, thyroid hormone. Thyroid hormone also, we know that it is a hormone. So it acts on each and every cell, and it has various functions. One of the function is that glucose metabolism. Glucose metabolism, it increases the glucose metabolism, and in the mitochondria, that is an increased production. Okay. So also thyroid hormone also, that is a than T3. Okay, T3, and so this T3 triod, okay, thyroxine. Here if you see this increases the glucose metabolism, and thereby increases the production of ATP. Okay, this is another. And next one is that glucocorticoids like cortisone, hydrocortisone. These are glucocorticoids, name itself indicates that. So they also regulate the metabolism. And these two glucocorticoids, if you see that, they increases the glucose metabolism, that is they increase the glucose synthesis either from fats or from gluconeogenesis or from amino acids. They increase the synthesis of glucose. So these are the four hormones generally, okay, so which regulate the, or regulate the glucose metabolism. One is insulin, another one is glucagon, another one is thyroid hormone. So thyroid hormone generally, it increases the, it involves in the basal metabolic rate, okay, it regulates the basal metabolic rate, and here it increases the glucose metabolism to increase the ATP production, that is energy required for us. And then next one is that glucocorticoids are also, this is steroidal hormones, okay, like your cortisone and hydrocortisone. They increase, they synthesize the glucose, okay, from, you have, that is gluconeogenesis pathway, or fatty acids will be metabolized, and this fatty acids also can be converted into glucose, that is glucogen, that is glucose, or amino acids also will be converted into glucose. So this glucocorticoids, they synthesize the glucose. These are the hormones which are generally involved in the regulation of glucose metabolism. But for the treatment of diabetes, okay, for the treatment of diabetes, we may not be targeting these pathways, okay. So we are targeting mainly these two, okay, or mainly one pathway only, because we know that it is increased levels of glucose. So this pathway will be targeting, okay. So with these are the hormones which regulate the glucose metabolism. And then what are the complications with the diabetes? So signs and symptoms, you can call it as, okay. So weight loss will be there, because, okay, generally there is a weight loss, you will in diabetes mellitus, and because you have the increased loss of glucose will be there, increased loss of glucose will be there, and it's because you have the higher plasma levels of glucose, and then this plasma will be transported to kidneys, and kidneys excretes the glucose. You have the increased loss, that is weight loss will be there, polyuria, and that is increased urination, okay, and polydipsia, increased thirst, because water reabsorption will be prevented. We know that most of the water reabsorption happens in the nephron. Water reabsorption, it will not be secreted. So but in case of diabetes, so you will have the polydipsia, and that is, polydipsia is because of loss of water through the urination. Increased urination is there, means increased water loss, and increased water loss, it causes the thirst, and polyphagia, increased hunger, and anyway that we discuss weight loss, and tiredness, and blurred vision. You have the blurred vision, okay, and that is because glucose will be transported in, okay, and it changes the lens, the shape of the lenses. Blurred vision, and headache, fatigue, and slow healing of cuts, that is, and itchy skin. So these are the signs and symptoms of your diabetes mellitus, diabetes type 2 diabetes or type 1 diabetes. So weight loss, polyuria increase, and polydipsia, polyphagia, weight, tiredness, blurred vision, headache, fatigue, and slow healing of cuts and skin. So these are the signs and symptoms. Okay. So with this, today's class